Thank you all very much. I really am grateful to spend some time with you today. And given that background, I think it's probably pretty clear that my forte is not in ambulatory nursing, but in a lot of things that definitely intersect, and have spent a lot of time with colleagues here and regionally and nationally in working through issues in ambulatory care as well from an infection prevention and control standpoint. So interestingly enough, when we were getting ready for the April event, when it was to be in person, it read Ebola, MERS, Measles, not in my clinic, because we needed to have our titles in, et cetera, by January. Well, obviously a lot has happened by then. We've got a new vaccine, for Ebola. MERS is sort of under the current now. Measles continues to be a threat for us from an infectious perspective. And then certainly we have a lot of work and a lot of good effort that's gone on in really promoting good infection prevention and control in ambulatory care for COVID. So I want to let you know I have no conflicts to disclose. Our learning outcome statement for today is after completing this learning activity, we hope to be able to have you be able to describe information and tools that you might use to combat infectious diseases currently at the forefront. And that could be just, pretty much anything. So this is just a small menu of a few things that, I particularly worry about from my focus in the world, but we also need to just remember the day-to-day infectious disease issues as well. So hopefully many of you have seen this visual, and if not, this is from the Centers for Disease Control, more particularly the agency within the CDC called NIOSH, or the National Institute of Occupational Safety and Health. What I'm going to do today is walk through for you and provide you a framework to use no matter what sort of infectious disease situation you've got, whatever sort of hazard situation you're working through. And it's really been useful to us, both past and present. So right now we're spending a lot of time working with schools. We're spending time working with meatpacking plants, jails, shelters, long-term care and assisted living, where we've seen dramatic increases in cases across the United States. And so today what I want to do is really provide you a framework for you to then take back and apply in your ambulatory care setting, and then also for you to be able to use this framework to help others, because it's very often that those of us in healthcare get asked by our community members, et cetera, to step up and in and help with kind of working through all the different things that are going on from a healthcare perspective in our communities. So if you look at this hierarchy, you'll see that it starts from the most effective hierarchy of control called elimination. And we're going to walk through and step through each one of these and actually apply them to some suggested applications within the world of what we're dealing with right now, which is COVID. The next most effective engineering or hierarchy in the control is substitution. So that's really when we want to trade something out, or can we substitute something for the hazard. Engineering controls is physically isolating people from the hazard. Administrative controls is changing the way people work. And hold that thought on PPE being least effective, and we're going to talk about the why. So let's start with elimination, which is the most effective thing we can do whenever we're in a situation where we're trying to mitigate risk. So elimination, again, is physically removing the hazard. It is the most effective control that we can identify. It's the most difficult to implement in existing processes. It might create or cause us to have a new design and create different options to eliminate a hazard, but the existing process as it exists may require major changes in equipment or procedure. So some people shy away from it. We would love to be able to eliminate COVID. But can we do that right now? The answer is no, we can't. We cannot physically remove the virus because we need a vaccine. So although we have to also remember that no vaccine is going to be 100% effective, and I did also give you a link there to a site that's actually quite good. It walks you through how many vaccines are in the varying different phases, of production. It's a rather complex situation right now as we look to seeing at what point in time might we have the opportunity for a vaccine, even once it's gone through all the safety trials that are absolutely required in vaccine production. We still need to develop the vaccine and production capability and then distribute, which can in and of itself require extensive amounts of time. So we'd love to be able to eliminate this hazard in the framework, but right now that's just really not possible given we have no vaccine. So next in the hierarchy, as far as effectiveness, would be substitution. Can we replace the hazard with something else that's less hazardous? And then we can think about this, and I want to use the analogy that we would all really fully understand. So back in the day when we had needle sticks and we were worried about bloodborne pathogens, and we still are today, think about replacing that hazard with something, substituting that hazard with something less hazardous. So the novel breakthrough of being able to implement needleless IV systems. That's a great example of substitution in the hierarchy of controls. So some other alternative substitutions might be looking at some of these newfound drugs that could help minimize the effects. So is it remdesivir? Is it dexamethasone? So we're just so early in this process, and there's a lot of work being done to really better understand clinically if that can really kind of begin to substitute and mitigate risk and buy down time of the illness and buy down the negative consequences of the illness in those who are more ill, etc. So again, elimination and substitution so far in COVID have been very hard to achieve. So next on the pyramid of the hierarchy is engineering controls. So this is where we really start to be able to do some things in all of our environments, whether it's a clinic, a jail, a long-term care facility, wherever. We can begin to think about how can we apply this framework to reduce down, buy down risk, so to speak. So engineering controls are when you physically isolate people from the hazard. So you want to design to remove the hazard at the source before it comes in contact with the person. The nice thing about engineering controls and why it's higher on the hierarchy than some of the other controls we're going to talk about is because it's not dependent on the worker, on the human, right? It's short-term cost, but long-term gain. So we've seen a lot of examples of this so far in healthcare environments and lots of different venues, meat packing plants. So some of the engineering controls that we may put in place, and again, remember, it's a barrier. It's physically isolating people from the hazard. So that might be your HVAC systems. So we really would encourage increasing fresh air intake, reducing recirculated air. Now, that's easier said than done in some of the older buildings. So can we instead implement some better efficiency air filters in the systems that we have? And I'm not an engineer and I'm not an industrial hygienist, but I'm told that there's different level of air filters. So if you can go up, it's going to have a little bit of cost to it. If you can go up in the level of air filters that you're currently using to filter the air that's recirculated, then that could in essence have a very good impact. Negative pressure capability. So obviously for airborne pathogens, droplets, etc., in this pathogen particularly, because we really had no experience with it, and in fact there's still literature coming out every day about the potential of really treating it as both droplet and airborne, and for the most part we've been working hard to try to as these patients who have been diagnosed with COVID are in the hospital, we've been trying really hard to get them into negative pressure rooms. I know that that's really tough in clinics and sometimes just simply not an option. So we need to think about what are the other things that could be done. I have been incredibly surprised and impressed by just working with the engineers of our facilities and in different venues, how innovative that they can become. And they have become. in trying to close dampers, change things around, take entire hospital units and turn them into negative pressure. You know, we always had a defined number, especially in our organization, and all of a sudden we were able to have this additional capacity. So I really encourage you to speak with your engineers and see just what might be possible or an option. Of course, adding ultraviolet technology or HEPA filtration is great if you can do it. And again, all of these things buy down risk and create sort of this barrier to the pathogen, barrier to the hazard that we can do without having to change the way we work, so to speak. So if you look at some of the pictures I've got here on the screen, I've got a couple from actually meatpacking plants. And some of these may be pertinent for you if you've got a very large clinic setting and you've got break rooms, right? It's one thing to do your absolute best with masks on out in your clinical space. But if we don't take precautions ourselves with one another while we're in common areas, on break, lunch, whatever, then we're not really going to be helping the cause, because we all could have, in our off time, come across somebody, maybe by accident or happenstance, whatever, and then the next thing you know, you've had an exposure, you might be an asymptomatic shutter, and somebody who just doesn't have symptoms. So therefore, putting some barriers in place might make sense in a busy, crowded break room. You could also think about maybe staggering shifts and some other things that we'll talk about in a minute. So another engineering control, you know, you just need to make sure in our enclosed environments, we really suggest no fans. We know it gets hot. We know that there are places that, you know, you just feel like you can't, you know, circulate the air, and some of the buildings are old, but we really highly suggest no fans, because you're really just moving the air with the virus in it, if anybody has it, and is potentially shedding the virus. So putting physical barriers in place in those common spaces makes a lot of sense. Does it make sense also maybe at your check-in counter or anywhere where somebody's going to have a lot of close contact with a lot of people? So again, an engineering control is a physical barrier of some sort, whether that's in your HVAC system or it's in the physical environment of your clinical space. The next big bucket in the hierarchy of controls is the administrative controls. And honestly, this is where the majority of all interventions right now that we can do fit. And what we like to share also is that it's not any one intervention that's probably going to make or break and be the difference, but it's really putting a lot of these in place to sort of close, you know, the Swiss cheese effect, so to speak. So administrative controls are about changing the way people work to mitigate the hazard. So it's used typically with existing processes where hazards are not well controlled. It's relatively inexpensive, but over the long term can be costly to sustain, and we'll talk about why. So some examples of administrative controls in all different sorts of environments, but certainly these all apply to the ambulatory setting, would be workflows. And we're going to talk about workflows in a minute. Is there a way to achieve unidirectional flow for patients, for staff? Is there a way to make sure that everybody isn't heading to the break room, the lunchroom, the restroom all at the same time? Physical distancing, is there an opportunity to use, you know, I see lots of neat sort of graphics on the floors to try to help people visually cue how far apart they are and how to get from A to B. So physically distancing does make a difference. Removing furniture. That's one thing I've done a lot of suggesting with places I've been to is, you know, if you physically remove the furniture instead of having 8 chairs at a table, then that really sends the message of what you're trying to achieve when people enter that space. Otherwise, we're again depending on the human nature of things to really self-guide that direction. Screening 100% of our patients and our staff. So this is an administrative control. Now, on the staff side, we may choose to say, you know, this is your professional accountability. Don't come to work sick. Please self-monitor. And that may be as far as you go. But on the patient side, you know, for the most part, I believe most ambulatory settings are 100% of the time screening patients, many times in advance of their arrival, but then again, sort of checking in as a gatekeeper upon arrival for that clinic encounter, so to speak. And it isn't just about temperature. We know that temperature is only going to happen, I think it's 60 to 70% of the time is where we're seeing a fever in people, but having clarity as far as the symptoms you're going to ask for is really important too. So shockingly, you know, one of the most odd symptoms is that loss of taste and smell. That might be the first indication for the patient and for you that perhaps this person has COVID. Enhanced cleaning strategies would also fit in the administrative controls. We're going to go into a little bit more detail about those, but making sure that there's routine, accountable, high-touch surface cleaning, that you're using the right chemicals, the right contact times. Workforce policies. I was speaking to a school yesterday and a bunch of leaders, and I said this would not be the time to have in place your perfect attendance policy. So, you know, whatever you need to do to be able to make sure that people know they can raise the flag, stay home, you know, when they're ill, is going to go a long way to helping them really understand that you're fully understanding of the need for them, and also not punitively impacting folks. And we really had to work hard with meatpacking plant leaders about this, because there was actually additional pay for no absenteeism and things like that, and that was absolutely not the right message to send. Communication and education are significant, and that's in every venue and every opportunity. So use of visuals, infographics, languages that meet the needs. So in many communities, we have multicultural languages and lots of opportunities there to make sure that we're hitting the mark and helping people to validate understanding. And then the universal masking process. So not the, in essence, the mask itself, which we'll talk about in a minute, but the universal masking process. So having some sort of process in place for universally masking is one of the administrative controls.